Hi, this is Roger Green, host of the Suffering the MASH Tsunami podcast. This week we're offering 5 conversations from episode 22, our discussion on the Healthy Livers, Healthy Lives Coalition, stemming from a presentation at the EASL Congress, joined by Jörn Schattenberg, Louise Campbell, and Coalition Chair Jeff Lazarus. From the vault, we have a discussion from 2023, how regulators and some providers hear and process patients' needs. This final conversation begins with Jeff discussing the challenge, answering the politician's pivotal question, how many people die of MASLD? As he notes, politicians are impacted by large numbers, and particularly large numbers of death. He cannot answer directly, but focuses on all the causes of death that are linked to MASLD. He notes, for example, that policymakers only took COVID-19 seriously when people started to die in large numbers. He points out that we are already seeing rises in liver transplant and liver cancer, and that these could be tied to MASLD prevalence. I share a thought with Jeff. It's not that people are dying from MASLD, but that they're dying with MASLD. To Jeff, and I quote, just saying this can make a big difference, end of quote. I ask how our listeners can support Jeff's work personally or through their companies. His basic answer, talk about the disease, educate constantly, and if you're involved with other metabolic diseases, make certain that SLD is part of the focus for that disease as well. The ideal end result, the World Health Assembly or UN events will be joint to several metabolic NCDs, including SLD. His last pitch before he leaves is for us to conduct an episode on liver AIM this fall. I commit to do so. Jeff leaves, and the last major thought goes to Jörn, who notes how much you can develop a field, including bottom-up approaches and bottom-up care, with a top-down vision and approach. I agree, but note that this might prove more challenging in primary care, where providers lack training, live deluged with new top-down tests and questions to add to their patient visits. We don't talk about public policy and MASLD very much on this podcast, except when somebody named Jeff, usually Lazarus, sometimes McIntyre, is with us, or when we're discussing regulatory decisions. This conversation moves fast and covers a broad range of issues, so just sit back, listen, learn, absorb. When you're done, join the conversation in our LinkedIn discussion group.
Jeffrey Lazarus.
Someone asked me how many people die of MASLD. I said, I'm not really sure that anybody is, but I do know a certain percentage is getting MASH, a certain percentage are getting fibrosis, and a certain percentage of those are moving to cirrhosis, end-stage liver disease, hepatocellular carcinoma. We know there's relationship, cardiovascular disease, diabetes, bidirectional. So when you know that someone has MASLD, you know that some kind of action needs to be taken. I do think that people need to know if they have MASLD, and I think there's things that can be done to help them to reverse it, even if MASLD hasn't been shown as a cause of death. That makes the case harder because policymakers tend to act when there's a lot of deaths. Just look at the COVID pandemic. We knew for a long time that SARS-CoV-2 was in circulation. Nobody wanted to do anything in January and February or even March 2020. And then when the deaths really hit Europe, action was taken. We're not going to see anything like that and in that way with MASLD MASH, but we are already seeing it as a leading indicator in some countries for liver transplant, increasing the indication for liver cancer. Those numbers really can't be denied. We're seeing it in the new GBD 2021 data. We're seeing it in the US transplant data, the Spanish transplant data. So that event will happen during the UN General Assembly. There'll be another event at the World Health Assembly, a side event. And the goal is to have a seat at the table. The goal is to be not in some hotel or in some secretariat banging on about this with hopefully have some WHO and Ministry of Health officials there, but actually be in that room and explain the urgency, but also explain that actually a lot is being done, but we do need to name this disease, put a name on it at the UN, at WHO, and then associate an action plan and a strategy to end it as a public health threat.
Roger Green.
So, Jeff, as we wind down, just a comment and then a closing question. The comment is, I think the issue isn't going to be how many people are, if you can frame it this way, dying from MASLD, or as compared to dying with MASLD, where MASLD is a contributory factor to what they're dying from, right? At F2 and F3, the leading causes of death, cardiovascular and extrahepatic cancers. So if we can find a way to reframe, I think that probably helps all of us.
I think you just did. So just saying with instead of from will make a big difference.
Okay, good. So that's number one. And then number two is, besides that reframe, and more generally, what can the people who are listening to this podcast do to support what you're doing? Some work in drug or device diagnostic companies, and a lot are care providers. And the third group are patient advocates. So let's think about what you think those three groups could do to help.
Well, a colleague came up to me and said recently that she was surprised so many people in her family had what she called fatty liver disease. And I said, well, this is the prevalence. And she goes, yeah, I know all that. It's just that when I started working in this field, field, all these family members started telling me that that this was the case. So I think it's about naming the disease, explaining it to people, explaining that they're quite lucky, in particular with this disease, because at the early stages, it's almost always reversible, and at the early stages, it can be reversed with few or no pharmacological therapies, with few drugs. I think for those listening who aren't in the liver field, there are easy things that can be done to test. We've already talked about the FIB4, but there are also other tests that can be done, also in other specializations where they can order an ELF, order a FibroScan, do a FibroScan, and so on, and use similar tests. And then I think for anyone working in other fields, it's important that those action plans, strategies, clinical practice guidelines include something on MASLD and MASH, and that when we're holding events in isolation, but we really should be holding these events jointly. So when we held one World Health Assembly side event on liver disease, or particularly steatotic liver disease, there were half a dozen on diabetes going on at the same time. So we should be in the room with them. They should be in the room with us. It's all part of the same health issue, because we're not going to make those changes just sort of banging the drum alone.
Okay, that's fantastic. We're at 11 o'clock, which is our closing hour. So Louise, Jörn, Jeff's going to jump.
Thanks for having me. Before I jump, I'm just going to put it out there, and then you can let me know offline. From the Liver Aim Coalition, where we have partners, both industry, academic, and clinical from across Europe. This is the largest European Commission-funded liver project running 6 years. Jörn and I are both work package leaders, co-investigators on this. We'd love to have a session with you in the autumn sometime and tell you about what's happening in Liver Aim. We're developing a large diagnostic platform to do an RCT with 100,000 people. Maya Thiele is helping to lead that. She was on the podcast recently. I'm leading the public health work. We're doing a lot of research now on regulatory pathways, on digital health and operational preparedness. The project, was launched just a few months ago, but maybe this autumn I'd be interested in having a few of those running Liver Aim to discuss and share with everyone what's happening.
Okay, so I'll make a commitment. We intend to do that sometime in October. That was one of the things I was referring to for the fall. The other possibility being whether anything comes out of the UN Assembly that's worth an episode.
I really hope there is. I think all of us should keep an eye on what is on that UN General Assembly agenda, and where liver health could have been actually and easily a part of the current agenda, which is too late to change. But we do want to make sure we're at the 2025 high-level meeting on NCDs, on communicable diseases. If we miss that, that would be a huge miss. That's the fourth time will have been the fourth time that there's been a high-level NCD meeting. And that's one of the reasons we're having this UNGA, UN General Assembly side event already now in September. We'll tell you, and maybe you'll be there, what happens at this side event. But I think we also need to look at what's going on in the room. Most of it will be publicly available, and maybe discuss, and maybe even with some of the people who were in that room, what it would take to get liver to have a seat at the table.
Okay, so please invite me. New Hope to New York is a really easy trip. I would love to be there. And with that, Jeff, thank you so much.
See you soon. Bye.
Bye-bye. Okay.
Jörn Schattenberg.
So, the one closing thought I have is how important it is to really include colleagues with the expertise of Jeff to move this to the next level. Because he said we're bottom up, but we're seeing those patients and we're in clinics. So the methodology or the systematic about how to develop such a public health approach and how to unite, again, three professional societies behind a common goal, developing healthy livers. And this is not only a metabolic liver disease, this is about alcohol as well, is so much needed, and really the support of public health experts much welcome. And I tell you the truth, in the past I haven't been too intimately involved with those aspects, and so over the last 4 years when I joined EASL Public Health Policy Committee, I learned on how much you can actually develop the field there, more from not from the bottom up, but the top down approach. So that's really, even as a physician, very stimulating.
Yeah, I couldn't agree with you more, Jörn. I think that there's a threat in terms of top down when you get to primary care, because those people get hit from so many different directions and they tend to adapt slowly. But that's a different conversation for a different day. At some point, I'd love to do an episode on what do we do about primary care, starting with what the needs are and then what are some approaches. And Louise, I'd probably bring allied providers into that conversation as well, because that's where the rubber's going to meet the road. And as you point out, even nurses who want to do the right thing right now, there is no training on cardiometabolic. So a whole raft of issues to discuss there.
And now, back to Roger.
We hope you've enjoyed this recording. If you have any questions or comments about the content of this conversation or the entire episode, please put them in the reviews section of the page from which you downloaded this conversation, or send an email to questions@surfingmash.com. Next week, Louise will be moderating an episode about challenges in communication between patient and provider and its implications on other systems issues. I'll miss the taping, but cannot wait to hear what emerges. Until then, stay safe, surf on. We'll see you on the podcast. Bye-bye now.